Well, thank you all for being here this morning. We're going to go ahead and get started. I want to welcome you to the December Arkansas Behavioral Health Integration Monthly webinar. We are so glad you're here with us today. Our focus is on all things behavioral health related, primarily with the integrated behavioral health focus. I want to remind you that by staying on today, you're giving us your permission to be recorded, and this recording will be posted on the ABIN website along with the ABIN slides. And so this month, I'm so excited to have this amazing group of people on with us. Whoops, I'm having a little bit of an echo. Y'all hearing that?
I think it stopped now.
Okay, perfect. Sorry, we're having a little bit of technical difficulties. We want to make sure we show some video of some of the work from the project. So today we have this amazing group of people because for the past year, we've been working together as a group on a HRSA project to train emergency rooms and peer recovery specialists together to place peers in EDs in several rural areas across Arkansas and several primary care clinics. And I'm going to ask Jenny if you would pull up our slides, Jenny, just so we could see the slide. Okay. And I think we're still having an echo now with this. Okay, now we're better.
Okay.
Thank you.
Unmuted.
One of the things that I really wanted to emphasize this morning is oftentimes when we're talking about integrated care, we're really talking about a team-based care approach. And so it's really important for us to think about peer recovery specialists as part of that care team and to think about the role the peer recovery specialist plays and how they fit in to that care team. And so this project was an opportunity for us to work with a diverse group. We were working with the care team in the ER. We brought in peer recovery specialists to be placed in those emergency departments. We reached out to subject matter experts that had emergency room experience with Dr. Martin. You could see Dr. Martin here with us. She was absolutely critical and essential to talk to us about, well, this is what's happening in the emergency departments, and this is how peers could potentially be best used. We were then talking to the peer recovery specialists about their experience. We were talking to champions and identifying champions from each emergency department and each health system, and making sure that those identified champions were really on board and they were going to meet and support the peer where they were. This was a process, as you could imagine, and it was really essential for us to incorporate all of the different disciplines as we were doing this. A few other things that happened with this project, we decided, well, one training is not enough, and so we developed something called a periodical. And in this periodical, we developed resources and information that would be helpful to the peer recovery specialist as well as the emergency department. So when the emergency departments got this information, it was, anything from specific screening to resources in the community. And we also want to thank HRSA for the opportunity to have participated in this project. Next slide. Okay, so as you could imagine, we had this great idea in the beginning, but there were lots of challenges when we were starting, as well as some successes. So we had to think to ourselves, how are we going to identify these different emergency rooms in rural areas, and how are we going to recruit them? And so we were fortunate. We had a relationship, and we were able to enlist the help of the Arkansas Rural Health and Primary Care Office. Michael Trevino was instrumental in helping us identify different emergency departments, as well as the Arkansas Hospital Association. We can't thank Pam Brown enough for really supporting us with identifying different emergency rooms that would find this helpful. Um, some other challenges of course, when we're thinking about any type of behavioral health concerns, there's lots of stigma associated. And then when we have co-occurring needs and substance use disorders, we definitely we're seeing that. So developing a stigma training, excuse me, that specifically addressed some of these issues. And peer recovery specialists were absolutely essential. It was essential for all of us to hear from the peer about their experience, and about supportive language, and about supporting them when they showed up to the emergency department. And we're going to hear a little bit from them. This is going to be a panel discussion today. I'm just giving you some brief highlights about some of our successes. So another thing that we thought was really helpful is CEUs are really important. And so we were able to provide CEUs to the different disciplines who came to the training. We did a training with the peers and the emergency staff in Eureka Springs. And then we were also able to get CEU approval for our peers. And so that was really nice. Next slide. And so now I have to brag. We have Megan Copeland with us today, and Megan is really the lead peer on this project, and her experience and guidance in this process was invaluable. And so Megan's going to talk to you a little bit about what a peer recovery specialist is and the role they play specifically in the ED.
Good morning, everybody. It's wonderful to see you all. My name is Megan Copeland. I'm Advanced Peer Specialist, Peer Supervisor in Training. And as Kim mentioned, I serve as the lead peer and project coordinator with ABN. So I want to, for those of you who are not aware of what a peer recovery specialist is, just give you a brief overview of what our role is and how we can be incorporated, best practices, things like that. So the first thing that I need to mention is anytime someone is a peer recovery support specialist, they have to have at least 2 years of complete abstinence from any drugs or alcohol. There's a 3-tier program in Arkansas, which is unique to the country. We're the only one that have the 3-tier program, which is a core, advanced, and supervisor. The core will go through 30 hours of training. The advanced go through an additional 18, and then supervisors an additional 24. There's also a code of ethics that we're all bound under. It looks a little bit different than that of a social worker because we are allowed to share our lived experience, which is a great benefit in making the connection with those that we're serving. So just a few things on this slide. We are non-clinical, as I mentioned. We are recovery role models. We advocate, and we also provide resources. Next slide, please, Jenny. So what is the peer's role? So number one, we always want to use evidence-based practices. We do a lot of goal setting with individuals that we work with, create recovery action plans, connections to resources, and facilitating recovery groups, which are peer-led. And so we do not teach, we facilitate. And what I mean by that is we'll start the conversation and let the peers carry it on. We just kind of guide them and create an atmosphere for safe sharing. What we are not is clinical, obviously, not in a power role. So we do not do things such as drug tests, assessments, any kind of medication management, or anything like that. Next slide, please. So what are the benefits of incorporating a peer? So there's lots of them, but just to give you a few, the immediate connection and understanding that is between a peer and someone that's still struggling is the by far the biggest benefit. We're able to reach them where they're at because we have that lived experience. There's a level of trust that creates a space for immediate progress. Access to resources. Those of us that are peer recovery support specialists have a huge network within Arkansas and surrounding states. So the access to recovery resources is great. Reduced demand on clinical staff, where there could be time spent by the nurse or doctor. We can step in and create a safe atmosphere for them and help them connect them to the resources they need. Recovery cultures within the workspace. So incorporating a peer specialist, it helps break down the stigma that occurs sometimes. And it's not of anyone's fault. It's just the mindset that people have had for years, thinking that it's a moral failing. And addiction is not a moral failing. It's a disease, just like if you have diabetes. So there are evidence-based practices that we can use. The side effects of addiction look different than that of diabetes. I mean, we don't have it. It's more like we turn to lying and cheating and stealing and things like that. And those types of side effects are easily understood by peers that have walked through that before. And last but not least, improve patient outcomes and reduce recidivism within the jail setting and reduce return visits within healthcare settings. Okay, next slide, Jenny.
Okay. And so just wanted to share with you some of the outcomes of this program before we really get into the important parts, which are hearing from the peers and hearing we have a representative from an organization of an ED here with us today. And so we're going to get to hear what it was like to have a peer in their emergency room. Um, but I also want to say with Megan, so you heard us say we did this initial training where we brought together ED champions and the peers. We provided some training for them together. We started that initial relationship from that moment. And from that moment, we were able to start identifying what were specific concerns, what were specific needs, and how could we start to address those. And so one of the things, and I have to brag on Megan because she did such a fantastic job with this, is it wasn't just let's put a peer in the emergency department, but how do we support the peer once they're placed in that emergency department? And so she was able to meet with them weekly and provide some guidance and supervision to them on the project. And we were able to hear things that were going well, pain points, and problem solve. So just want to say thank you for that. And one of the things I think that's really critical in this type of project is learning from each other. So you could hear what was working in one ED, what was one peer doing that was successful, and then another peer might be able to learn from them. We were really pleased with our outcomes. We really only had the peers in the EDs for about a 6-month period by the time the program got launched. But you could see some of the things that really were positive that happened in the ED. We were able to help peers find programs for medication assisted treatment. We were able to provide them with Narcan. We were able to help address some of the social determinants of health needs. We were able to steer them and some peers were able to bring them to recovery meetings, talk to them about different treatment options, talk about multiple pathways of recovery, and what works for one person might not work for another person. And I think for me, one of the amazing things that I saw in the project is sometimes when people come into the emergency room, they might not be ready for treatment. They might be stabilized, but at that point, they might need the service of the peer who could just say, I've been there, I've lived that, and I'm here to support you. And like Megan said, um, it's not saying here's your treatment and we're going to discharge you. I want to ask you, Dr. Martin, I don't know if you have anything to add to that about when people come to the emergency room, are they always ready for treatment? And how do you see a peer fitting into that specific area?
Sure. Thank you, Kim. And I've had a lot of people that have come to the emergency room, not always necessarily for an overdose, right? But they may have some other kind of associated complication due to their use disorders. And I have told this story a few times, but over and over again, um, taking a few minutes as a provider to address that and to connect people with a warm handoff or let them know that there is hope. Um, I will have people almost every shift I work in an ER, there will be somebody that stops and cries and says, nobody's ever asked me if I wanted help before. And so a lot of them are desperate for that help. They just don't know how to overcome that and how to connect with that. And I think as as hospitals and ERs, it's not enough to hand people a meeting sheet and say, hey, here, follow up. Or here's some numbers on discharge sheets. The people that were successful that we still see today that come back in the ER later for a runny nose or something like that are the ones that we've connected with peers and given that opportunity to kind of dissect and figure out what it is that they need. And a lot of times patients don't have the insight to know even when they've overdosed because they may wake up in an ambulance and they don't feel like that's happened. And so being able to have peers available to work not only with a patient, but even family members seeking help has been vital to people's success.
Awesome. Thank you for sharing that input. Who better than someone who's right there in the ER? Next slide. And so one of the things that we did that we thought was really important was how do we identify patients? Oftentimes patients may not be telling us that they are using, and they might not be there to talk about their SUD. However, if we could screen in the beginning, it's an opportunity for us to identify patients, and then we could have an intervention. A couple of screeners that can be really helpful are the Audit C, which is just 3 questions, or the CRAFT. If either of those are positive, you could do a full assessment and then incorporate the peer specialist into the brief intervention and do a warm handoff to them. Next slide. The next slide is a workflow that we saw that we thought was really helpful. Once a patient was identified and an assessment was done, if you could create an alert so that the peers were notified that there is a patient in the emergency room, and a best practice alert would say, please notify the peer. So as soon as possible, you could let the peer know somebody was in the ER. And if the peer was not physically present, we could try to get them available by phone. Next slide. And I have to talk about our amazing team. Jenny Post is on, and Jenny is the developer of the periodical. And so monthly she was developing this and making sure it was getting out to all EDs and it had relevant information that could really benefit them. Next slide. Okay. And it's important that we have data. Data tells the stories. And so HRSA likes to see outcomes and what did we do. And this can give you a visual of how many individuals were able to receive treatment, went to recovery meeting, were referred to recovery meetings, and are actually brought to recovery meetings. We've had peers that went to meetings with individuals. People were brought to treatment. One of the things that happens in some of these traditional models is it's really hard if somebody says, yes, I'm willing to go to treatment. Maybe they don't have a way. And so peer recovery specialists are able to do that. Housing, and then you can see naloxone was a big push. Next slide. What we were actually, this project was featured in the Arkansas Hospitals magazine in the fall of 2024. And so they were able to share the information that's happening for this project, for other projects. I have to say, we now know the Arkansas Department of Health also has a program. They have a grant that just started to support peers in the ED. I think that's happening in 4 rural hospital or rural EDs now in Arkansas. And HRSA was really pleased with the outcomes of this project. They encouraged us to continue to have this type of project in Arkansas and look for opportunities. So we're so grateful that the Arkansas Department of Health has this project that they are doing. And as part of this work, we received the Community Star Award for Arkansas. And we were also chosen to speak about this project at National Rural Health Day. So I was really excited and grateful for all of the work that happened with that. I think it's important that we see, I think the next slide might be a video. There's a couple of peer spotlight videos. We made one for every peer. And the purpose of this is we wanted every emergency room to see that there was someone in their community that they could connect with and as a resource to help people who are struggling with SUD. So we've got this peer spotlight video, and then we're going to hear from the peers themselves.
I am a person in long-term recovery from a meth addiction of 19 years. I've been a peer support specialist for 3.5 years in rural Arkansas. The unique thing that I see a lot is the stigma. There's no resources there available in the rural counties at all that I serve. How do I support and engage the individuals that I work with is that I try to get all the resources. I collaborate with other peer support specialists to find whatever they need, whether it be food pantries, jobs, treatments, whatever that we need to do, we do it all together. So peer support is somebody that is in long-term recovery from substance abuse or mental health disorder that will walk alongside that peer through whatever that they struggle with. So my name is Cassie Cooper. My phone number is 870-201-0445.
My name's Jeremiah Wool. I'm from small town Arkansas, St. Joe. It's in Searcy County. We're in an extremely rural area. National forest is what we're surrounded by. We've got the National Buffalo River that goes through there. Generally, out of 132 people, I can't even see 8 of them with binoculars. That's how far rural we are. There's not a lot in between. There's nothing there for as far as jobs in sense, but it's just natural forest. Being a part of a small community my whole life, I've got an ability to really talk the language, to get to the lingo, to understand exactly where the peers are coming from. How do you get down to somebody's level like that and understand that that's the core of principles that rural people have when they're developing? It's this closed-minded, almost in a sense that this is what we do for life. I get to share it and have an experience of we can talk about the things that are around us in our area, but let's talk about the things that maybe we don't know, that maybe doesn't exist here. What does hope look like? What does a good life stand like? What is sustaining a recovery where you don't even have to have the dereliction that we suffer in the rural areas? My name is Jeremiah Wool. You can reach me at 870-577-1569, or you can reach me by email, jwool@rcozarks.org.
Right. So,
I am
thank
a
you.
person in long-term recovery from
And Thank you, Jenny. One of the things that, as I said, I think it was so helpful for EDs to know they have a peer in their community, in their county, and this is a resource, and these videos are resources. They can have them available. They can play those videos. Those are resources that they'll continue to have.
I
Okay.
love Jeremiah Wool's enthusiasm in that video. It makes me smile every time. He was so excited to share, and that was fun. That was a fun project to do.
Absolutely. It is awesome. Okay. And now I'm going to turn it over to Megan, and we're going to hear a little bit about a panel discussion from the peers themselves, what it was like to be in the EDs, and our healthcare representative, Cassie Day.
Let's do it. Okay, so our panelists today are going to be Dr. Kristen Martin with River Valley Medical Wellness, Cassie Day, LCSW with White River Health, peer specialist Nicole Hanners, Brittany Joslin, and Frank Frenzel. So thank you all for being with us today. I just want to say to everyone that's attending the webinar, if you have questions along the way, please feel free to drop them in the chat. We will monitor them and answer them as we can. And then we'll leave a few minutes at the end for questions as well, if someone can just help me stay on track with time. Okay, so let's just jump right in. What are some of the most effective ways you have found to incorporate peers in rural healthcare settings? So anyone from the panel that would like to start us out, and then if anyone has any follow-up, any of the panelists have any follow-up comments or anything else that they would like to share, please jump in.
So, hey, this is Dr. Martin. We've integrated peers into multiple rural healthcare settings, certainly our outpatient clinic, and I'd say to providers, start by hiring one. But with the emergency room and hospital settings, I think if you're a hospital or clinical team, knowing who the peers are in your community, if you don't have one hired, you can get on the state website and look and see who they are. If you are a peer, go by those hospitals, leave your information. Don't go by just once, go by at different shifts at different times, because it does take people a little bit to get used to like what you're capable of. And I think as far as incorporating them, having a champion in your hospital or on the different shifts can really help with that, to remind people when it's a busy shift or things are going on that, hey, let's call the peer and see if they can help us out with this. But leaving business cards, leaving flyers, reminding people is really, as a physician and healthcare provider, I need reminding sometimes of what's out there, especially when I haven't been used to using peer resources. Now I'm 4 or 5 years down the road, and I have 6 of them that work for me. But it takes us a while, so it's not always that we don't want to use it. We just don't always know how to use the resources. And so those are my suggestions from a provider sense.
Any peers want to follow up on that?
From a peer standpoint, I worked in 3 different settings, 2 EDs and a mod clinic environment. And I'll have to say that I have to agree with Dr. Martin on the champion is in my situation was crucial. The environments where I had a champion that was going in and letting the staff know that I was coming in, that I was what my roles were typically going to be, was crucial to really the acceptance of me walking into that space. However, the staff changes. Like she said, you have to come back in. You have to continually let your face be seen. You have to tell them, "Hey, I'm here. This is what I do." Because in a busy ED, things get hectic, and you may not be what they're going to think about in the heat of the moment. But if you come back and you keep reminding them that you're there, then and and typically, if you're not, if your face is not seen, they're not gonna remember you. So, walk around in a non-busy time where you're not gonna be in the way. Let them see your face if you're working within that ED. But a champion for me was crucial. I worked in 3 locations, and the 2 locations where I had a champion that was showing up for me, um, was crucial. I had one location that my champion was kind of out of sight, out of mind. She really didn't have much contact with me. I picked up another champion that wasn't enlisted per se, and that kind of was Cassie Day, and but vital. A champion in that environment is vital, I believe.
Thank you, Nicole. Cassie, as someone that stepped into a champion role, even though originally not assigned as such, which we greatly appreciate you for doing, can you share your experience on integrating peer support and what that looked like for White River Health?
Um, there's a lot to say about it. I'm looking at all the questions, trying to make sure that I don't answer other questions right now. Um, I like if I could go back, I would do a lot of things different. Because I kind of like was just thrown into a position, not thrown into it that I wouldn't have done it again. But it's just really fortunate that Nicole has the attitude that she does, and the education that she does, and the knowledge and stuff, because I don't know that anyone else could have done that position. I think it would, there's a lot of, I don't know if it's a rural area or if it's Batesville rural area. It's just kind of a different rule. I don't know if you know about Batesville, but so they're just not, it's just different. And so she was very assertive. She asserted herself and made herself known. And even though that there was a lot of tough um, things that she had to go through and statements that were made and looks that were made, she never let that bother her. She just made that as a learning experience and to come in even with her head held higher and her shoulders back more, And I think that's what's really important, is to know that the stigma is out there for everybody in everything. People are going to talk about you, but just important to just constantly go in the way Nicole did, with I know what I'm doing is for good, whether you believe it or not, so I think peers need to be in everything. I think big businesses like Walmart and places like that should have somebody in their HR just there I mean, because this isn't just, we're not just talking about drug and alcohol use. We're talking about mental health. We're talking about just, do you need some services? I really feel like they need to be everywhere. I'm overjoyed with peers, so I don't know that I don't have anything negative to say or anything. I think they're great, and I think we need to incorporate them everywhere, and we need to let them build somewhere. So
Amen to that.
Yay!
Okay, we'll move on to number 2. What strategies have worked best to engage people who have overdosed and make sure that they get the follow-up care and treatment that they need, especially in rural areas where services might be limited or harder to access?
I think with the peer and the ER, it was a little difficult because if they come in overdose, they usually go straight to our ICU. And then Nicole kind of got lost in the mix from that. The only way she might be able to follow up with them was if they ended up in our psych, and then she did a group. So that was the way to follow up. But I think I think the people that come in who have overdosed get kind of lost in the mix, being able to see a peer. I think so. I think that's kind of hard.
Hey, this is Dr. Martin. I have found that there are, depending on what has been overdosed, and that the decision tree of both the emergency room providers and the patient that a lot of times, again, people may not have the insight, and did they overdose or they're angry when they get reversed. That and they feel bad, right? I mean, they feel bad. And so for hospitals and medical providers, there's the big push for people that have overdosed on opiates to provide DEA's change its regulations to provide people with buprenorphine, always giving naloxone in the emergency rooms, and there's lots of it sprinkled around the universe, or prescribing that, but it's better to provide that in hand. And providing people immediate solutions, even if they don't acknowledge it at the moment, getting them the number of the peer or resources. I have found, 4 hours later, 8 hours later, the next day, that whenever I gave that to them and let them know that there would be no judgment if they called back and decided that they wanted help, that they oftentimes did take advantage of that. But there is a network and resources, and there are facilities that will take people for withdrawal management, we've referred to as detox, or get them in more immediately. That the peers know what those organizations are, or we've tried to distribute it through the emergency rooms all across the state, because there's a small window of time that people are usually willing to accept to get help. But I always want them to know that they can come back if that choice is later.
Did any of you peers have an experience with someone that had overdosed whenever you were on duty and that you could share?
I had a young lady come in and she had overdosed at her own hand. It was a very emotional situation. She was very young, and just she was obviously referred over to a psych unit, but she, the you see a lot of the hopelessness that comes in with psych patients, that and peers that come in. And this young lady, the thing that had sent her over the edge to decide to take a bottle of pills, but she was stabilized, and then once stabilized, they came, and that was a situation where I was able to come in. They got her stabilized in the ED, and I was able to come in and sit and speak with her, and she was able to make the choice to go and get some help, and so that had a positive outcome. Her mother later contacted me and thanked me for meeting her where she was at, and having a conversation with her about some things that I had walked in, and she said that she thought it might have made the difference for her. I later saw her on the psych unit. She did not choose to come to group, but I did look in on her when I was there, and so I mean, they haven't reached back out to me, but the last time that I spoke with her mom, she was doing well on her medication, and progressing well. So, but those situations when a young person comes in, 18 years old, and has tried to take their own life, it's never easy. But, like I said, she made the choice herself before it was made for her to go to a psych, to adult psych. And one thing I love about White River is they have an in-house detox and an in-house psych unit. So all those needs can be met right there. And then, as a peer, I had access to both of those units, so I could come back later and see those peers, either on the psych unit or in detox, and follow up care there. So
Thank you for sharing that, Nicole.
I'm just gonna dovetail on that real quick, because I love it for locations that actually have those available, but most rural locations in the state, a withdrawal management facility is at least an hour, if not more away. And so one of the problems that we get into is that for withdrawal management, it is not paid for by an ambulance service to take somebody to treatment, right? If you can be in a hospital detox, possibly with overdose, like intentional and things like that. But otherwise, what most people realize is if somebody says, I really want to go to treatment tonight, that ambulances will not, we can't just say, oh, okay, let's send them over to natural state or wherever in the universe, any place. So people have difficulty with rides. And that's one of the areas where your peers can help provide a ride to somebody because they're not safe to get into a car or usually won't go. And so that is a big advantage because we don't have a way to get them there out of emergency rooms if there's not somebody that's safe that's willing to drive them to a facility that accepts people on nights and weekends. So just a heads up.
Great point, Dr. Martin. I'm glad you said that. Frank, were you going to share something earlier? Did you want a moment?
Yeah, sure. First of all, I want to say it's a pleasure to be here with y'all, and it's been an honor to work on this project. And I know I don't speak for myself when I say that it hasn't ended for me. My level of commitment is well beyond getting paid for it. So I just want to say that. But I want to thank Kim Schuler and Megan and Misty and Jenny. You guys have been invaluable to this project. Anything I've needed, any help, any suggestions, that our weekly Zooms were fantastic. As far as the overdose issue, I was pleased to hear recently from another fellow in the recovery community here in Harrison, Arkansas, that our local hospital is thinking about a detox, which is fantastic because generally, if there's somebody who needs treatment, mental health or what have you, they go from emergency, like right off and get shipped. And they never really incorporated me with those things. And I was well aware of some people who were shipped because they actually were peers of mine here in the community in my recovery program. What really seemed to work for me, aside from like what Nicole said, being there, being present, was when they did have somebody who did need mental health treatment and also had substance use problems. They went from emergency to CCU, and I would show up religiously twice a day for nearly a week with a couple different patients. And when those people got to see me show up, and and they say, well, I think she's sleeping. I peek in to see if they're sleeping, and I'd go. But that level of commitment to show up and let them know that I'm not just the one-time phone call, and it's probably not worth telling anybody about this guy. He shows up religiously twice a day to visit this person in the hospital. Their family doesn't even show up that much. So it's that level of commitment. You really do. I don't have to pretend to care. So that's what makes the commitment easy. I do care. And when I have a chance to make an impact on my local community, I'm going to do it. And like I say, I'm still doing it. I look forward to this project to continue in whatever form or fashion it can. But like, just going to back up what Nicole said, being ever present. And I didn't get to experience working with Nicole, but I could tell from our Zoom meetings that she does show up with her head held high. Doesn't matter what people have said or will say. She's a warrior in that aspect. And I appreciate that about you, Nicole. It's an honor to know you. And that's really all I got to say, guys. I'm just honored to be a part of this.
Awesome. Okay, so it looks like Brittany's having camera and microphone issues, so that's why she's not chiming in at this time. So since she's having technical difficulties, we'll just keep moving on. Is there anything you would add to or change in the program?
I would like to chime in on that. So with the nurses in the ER and stuff, everything is automatically populated, so like if a doctor puts something in, he doesn't have to ask the nurse, hey, can you go, he just puts it in and it's automatically on the screen. I think it would be really helpful to have something automatically populated to, like, if they do a screening or if they just have a feeling, they need some help, where they could have something where they could just, I don't know, click something to automatically populate to the peer to be able to contact that person. Maybe they're not there. And so whenever they get there, if maybe it's a slow day in the ER, they would have all these contacts that they could go back in and contact. Hey, how are you doing? How was, your visit? Is there something I can help you with? I wasn't here during that day. So, I mean, we really rely on automatically populated things in the hospital in general. Even for me, When something needs to be done, it gets automatically populated. Social services needs consult, and so they weren't incorporated in any of that automated population. And I think that would help a lot, especially in hospital settings.
Thank you, Cassie. Dr. Martin, can you share how your clinic handles those handoffs to peers?
So, in our clinic setting, whenever somebody comes in as a new patient, that is part of our I'll say addiction medicine program, because it doesn't necessarily have to be opioids. We treat all substance use disorders and other addictions, behaviors and things. We, as a new patient, I have each one of them. I tell the patient, I say, this very first time, I'm going to have you come over here and meet the peer. And even if you choose not to follow up, that's okay. I want you to meet them and get to know what they do. And I'll train you on the naloxone. We're going to give it to you free. Because I think that having the warm handoff, if you just tell somebody, hey, call back later if you need any help and stuff like that, people just don't overcome that barrier. And whenever they can meet them face to face and realize what all they can do, and that they're not scary, and that they have lived experience and can share and understand, then we get much better results that way, as far as just a few minutes of a warm handoff makes a huge difference for the interactions of our patients and their consistency with connecting. So that's one of the things we do. But
thank you, Dr. Martin.
Uh-huh.
So let me go back to what would you add, or what was it? Change in the program. Do any of the peers want to speak on that?
I want to put a Dr. Martin and a Cassie Day in every ED across the land. Absolutely. Is what I would like to do. So for me, really, I found there was I think there was a lack of screenings going on. I think the importance of doing those screenings in the ED are vital, not only to incorporate peers, but just in general. And I feel like sometimes maybe things get rushed, and some of those practices are kind of left by the wayside. At least what I experienced. Also, some education with the providers and the nursing staff. At least I can only speak for the EDs that I was involved with, but there was a lot of stigmatizing language that I would hear and overhear, and just, there was sometimes there was situations where I felt like they wouldn't come and get me because they felt like this individual would be like a lost cause. And I feel like, if there was more education, and if they knew more about peers and what we do, and they could see more of that spark of hope, and I know that as providers and the nursing staff and EDs, they see this population coming in repeatedly over and over. And it gets frustrating, and we get desensitized to the population. And I understand that. But, I worked with an individual that came in 4 different times just when I was in there, and he's now in a recovery program. So, I mean, just coming back, that if they keep coming back, then, I think there's hope there. But if more education could be provided, and then letting the providers and the nursing staff know what a peer does. I mean, I don't know that any of the staff from the EDs that I was involved with even came to the training, but I think that as we incorporate peers into the EDs, if we could have, someone like Dr. Martin, who has worked with peers so much, or Cassie Day, that has worked with peers so much, that could come into those ED departments and educate the providers and the nursing staff and the social workers that are working in those environments, and educate them on what peers, who they are, what they do, the services they can provide, and that they can potentially make a difference in someone's life. I think that's vital.
I'm going to dovetail on that one too. So we actually had a project the last couple of years that we tried to reach out to different staff, and we have some videos made about what peers are that was SAMHSA funded, and are happy to talk to any of the providers. It takes time to overcome the stigma and for integration that way. But I personally am happy to talk to any ED providers or nursing staff and things like that. And I hope that we continue to do that outreach. Because it's becoming more accepted, more understood, and is so vital. Once people understand what peers can really do, I think they don't want to let go. So,
Thank you both.
I'd like to say something real quick if it's okay. So my rounds included 3 departments in the emergency room and 3 satellite clinics for North Arkansas Regional Medical Center. And just to be completely honest, the success for collaboration was about 2/3. One of the satellite clinics, excellent relationship with those at the front desk. They called me religiously. The 3 departments, emergency, OB, and CCU at the hospital, great relationship. A couple of the other satellite clinics, not so much. And it wasn't for a lack of my presence. It wasn't for a lack of me educating or handing out flyers. I do feel, though, like Nicole said, there's a mindset and there's stigma. And it was a lot of smiling and happy nodding. Oh, yeah, okay. And I'm not trying to criticize anybody because I know some are overworked. I know what kind of flow that those 2 other clinics see. But then again, so did the other clinic that I dealt with too. They had quite a bit of flow there. There's a lot of doctors' offices in there for different specialists and whatnot. But my success rate was about 2/3. I want to say that, and I don't know how I could have broken through to the other 2 clinics. Like I say, I was ever present. I showed up when we had agreed the best days would be. But I do believe somebody sang about 2/3 not being a bad number. So I'm happy with that, but I really do wish there was a way. I couldn't get anywhere but the waiting room. Whereas in the other departments, I can circle around, I can talk to every single nurse sitting at a computer in the hallway. It was a little bit different. And I do believe I broke the stigma because of my personal relationship with that hospital. Some of the people recognized me from an incident that happened some years ago. And to see me walking there, helping people like myself, some of them thought it was quite amazing. But I really don't know. I would really appreciate somebody like the doctor being able to I don't know if FaceTime or however it would work, but to let these people know that this is a valuable resource. This is an evidence-based practice, and there's no replacement for lived experience and that shared look when you say, hey, listen, I know what you're going through, and I give them a short story, and they're like, sounds like you know what I'm going through. But yeah, 2/3 was about my success rate. I just wanted to say that.
Thank you, Frank. Okay, so we are down to 6 minutes, and there are a couple questions in the chat that I would like to address. And then if we have additional time, we can open up for maybe a question or 2. Sierra Anderson said, I know when I was a probation officer, the judge worked hand in hand with me to find a place that would find a location specific to each person that needed assistance for treatment. We would do what we could, and the case would be continued until the following court date to double check and see if the individual had assistance. So that was a statement, not a question. Michelle, I don't want to botch your last name. Bilodeau, I'm gonna say. I apologize if that's wrong. Her question is, in terms of sustainability, what are the biggest challenges experienced that lead to relapse in the journey to recovery? Piers, do you?
That's an easy one. That's an easy one. There's a million answers there's a different answer for every single substance user out there. Obviously, we're all very unique, but like I believe it was the doctor said, some people have never been asked, do you want help? Some people have never been approached with somebody who's gone through what they've gone through and said, hey, there is hope. not only is it better being sober or being stabilized, getting some medication for your mental health disorders, not only is it better, it's great. And it's a lack of hope and it's a lack of support. And that's exactly what we provide as peers.
I couldn't say it better, Frank. I think you hit both of those right on the head. Okay. 3 minutes, y'all. Do we have any questions from the crowd?
Let's go peers.
Thank you,
Cassie?
Cassie.
I think we need a Cassie to make rounds to all these clinics and emergency departments and vouch for us. You might stop by Walmart too. That was a fantastic idea.
No questions. I know someone has a question.
When does the project start up again?
It never stops, Frank. It never stops.
I know. I just miss our weekly Zooms.
Absolutely.
We are working on it as we speak. Not literally, but in an hour, I will be working on the next grant proposal.
Absolutely, Frank. I think that's a great point. And you know, sometimes these programs get started and grant funds only last so long. And so it's essential that we look and we start thinking about sustainability. You know, one of the things that we've talked about and we know is essential when we're thinking about team-based care, if we could incorporate the peer into that care team, then instead of billing for these individual services, maybe that bundle payment could incorporate the peer in there. So I don't have the answer to that today, unfortunately, right now, but I absolutely believe that it's needed. And know that as we're looking at projects and as we're talking about care teams, peers are front and center in that role. So. And I just have to say, I know we're almost at time. When we first started this project, we were like, whoa, this is a lot. There's a lot of barriers. Initially, you know, EDs were really hesitant. What we wanted to do and how are we going to do it? But I just want to say, I am so proud of everyone on this call. You guys have been persistent, and I think the term warrior was used, and that definitely describes everyone on here. You all really are warrior advocates. You know, we've got our peers. You are out there on the floor in your community, really having to break down the stigma and convince the communities to allow you in. We had Dr. Martin, who was our subject matter expert, and we can call and she would provide us advice and she'd say, well, this is what I see that's been effective in the emergency department. And really was an advocate as well. And then people like Cassie Day, who says, you know, I don't really know. My organization doesn't have a champion, but I'm going to step in and I'm going to be the one who promotes you, and not just in the project, but she's promoting this all across the state. And so we're so thankful to each and every one of you. This project has really been a success, and you hear from the stories. So many people's lives have been touched, and recovery is happening because of people like you, the peers who have been able to reach out and provide hope. So thank you for all the work you do. I know it's hard. There's a lot of hard work out there happening, and we're so grateful. I hope you have a wonderful holiday season. And if you have individual questions or want information, don't hesitate to reach out to us, or Frank put his information in the chat. We're available and we'd love to help. Have a wonderful holiday. Bye-bye.